Hi, everybody. I'm so excited to be with you today. I'm sorry we can't be in person, but at least we get to see each other this way. I know that San Diego Pain Summit has become one of my very favorite weeks, and this is my third year in attendance, and I know a lot of you have been going a lot longer than that. So I do hope that you'll enjoy my presentation. And before I even begin, I just want to thank all of you for being here and for spending your time continuing to learn so that you can be the best clinicians that you know how to be. And I hope that the things that I have to share with you today will continue on your journey with that. So the tale of two stories, huh? In every clinical encounter, there's a clinician and a client or a patient. We give them all kinds of names, right? But there's your side of the story and there's my side of the story. And I kind of thought in the wake of 2020, the opening of A Tale of Two Cities was appropriate. It was the best of times. It was the worst of times. It was the age of wisdom. It was the age of foolishness. I had no idea when I named this talk months ago that we would be in the situation that we're in now. I can tell you that. But my goodness, how universally true is that sometimes we see it as the best of times. Sometimes somebody that's been in the exact same situation as us sees it as the worst of times. It's amazing to me that when telling a narrative, there are always multiple sides to the story. So today, I'd like to just enlighten some of our clinical encounters and maybe some reasons behind why clinicians and clients don't always see eye to eye. Well, we know that resilience and self-care are important to patient success, right? We know that creating a third space for collaborative learning is something we're supposed to do, and motivational interviewing, and in the words of Sandy Hilton, we're supposed to try to be less wrong. We know that PNE has a place, but that it's not a cure-all. And we know we're supposed to listen. And we know that we're supposed to help create resilience, self-reliance, self-compassion for ourselves as clinicians, and to encourage our clients to feel compassion for themselves. We sharpen our skills. We debate online. We discuss modalities. We stay current with the research. We follow people, we listen to people, we create social media so that we can share with each other. And I know Rajam honors the patient voice over and over again. And so I would like to slide the patient voice into this discussion as well. Clinical encounters, no matter how brilliant we are, can often still be challenging with people experiencing persistent pain. For a moment, I'd like you to think about why you came into your job. What was it that drove you there? I'd like to suggest that maybe it was the heart of a fixer or a helper. That you came into this medical world that you're in, be that a doctor, a chiropractor, a physical therapist, an occupational therapist, a massage therapist, an anesthesiologist, a physician's assistant, but that you came into medicine because you wanted to make things better. This is a personality type. This is a way of being from the inside out. And it has biases that we are often unaware of that come with it. Despite the fact we know we are no longer supposed to fix biomechanical problems, in our nature to help, I think we often approach clinical encounters as though we're still looking for something to adjust. We're still listening to stories with care and not interrupting, but we're still looking for the information that we can fix. I encourage you to do a self-evaluation and decide, is that the way that you are coping with the monsoon of information that we get? I'll be the first to tell you that I know I am. I definitely approach even my coaching consults sometimes as though I'm looking for the item that can be fixed. And I still forget to really listen for the sake of listening. I took some narrative medicine classes with Julia and Lysantha over the summer before last. And if you haven't taken their classes yet, I'm going to make a shameless plug for them and say, please consider it, because they gave me a new way to look at story and to look at my bias for the way that I look at story. So when you are listening to your client, I encourage you to really listen like you're listening to a friend and not like you're trying to diagnose what the psychosocial problem is if we can't find the biomechanical reason. Remember that we value information. We are learners. We are seekers of the answers. But that may not be the client in front of us. We may be sharing irrelevant information that they may not be ready for. I kind of hate that as a truth, and I'm sure that you will too, but often we go to share information in our desire to help that our client may not be ready for, and we need to consider that. They may be looking for the answer on how to sit on a car ride to go visit their friend, and we want to explain all about their nervous system and how things aren't right, and we've got these great tools that we can give them, and in reality, we may just be talking. So how do we know when it's time to share, to teach? I'm going to offer to you that I think the best way that we can do that is by asking permission. Asking if the information's wanted. I mean, how many times have you sat in a group of friends over a beer and you've been talking politics or religion or one of the no-no conversations, right? And you go to say something and you see that look on your friend's face like, oh God, here they go again. Our clients have those same looks, and we need to continue to hone our skills to get better at that. A second reason that our clinical encounters are often different, that our patients report one thing to their friends and we report another thing to our colleagues, is that I've noticed online we talk a lot about post hoc reasoning and confirmation bias, anchoring biases, and sunken cost fallacies. Amongst clinicians, we point these things out to each other and we attempt to hone ourselves and grow and to be aware of all of our biases. In the midst of this, do we consider that our patients also have biases like these? I ask because as a patient for 20 years, now recovered, I can absolutely tell you, undeniably, I thought kinesio tape worked to hold my SI joint in place and lift the skin and have better interstitial exchange that was taking my inflammation away and doing all kinds of magical things. When maybe it was just the fact I could put it on myself. That's probably more likely. But the point is, as a patient, I was also really good at post hoc reasoning. Well, clinician B, I felt better when I was with them than clinician A. So they must be a better clinician, right? Because I felt better. Confirmation bias. Oh, come on now. We do that all the time. As patients, we seek out the clinicians that agree with us. When you disagree with us, you're dumb, or you're stupid, or you don't know, or you're uneducated. So, in my case, if you'd wanted to tell me that my SI joint was indeed not out of place, I would have said you were uneducated. You were not confirming my bias. You were trying to correct really wrong information, but maybe it wasn't the time or the place. Anchoring bias, the very first explanation we're given for our pain. And then the well-meaning clinician comes along and tries to change that. How well does that work with our colleagues online? Sunken cost fallacy. This is my favorite. Okay, I know as a clinician I have sunk a ton of money into continuing education to be as least wrong as possible, to be up to date, to learn from those that know way, way, way more than I do. And you know what? It still doesn't touch what I spent in clinics and tests and things as a patient in pain. So when we talk about sunken cost fallacy, I wouldn't be surprised if your patients have more sunk into their explanation than you do. We have to be gentle when we notice these things, right? Because we hear them because we've become good listeners. And we use our motivational interviewing skills or our intuition to gently confront some of these thoughts and beliefs. But do we stop to assess whether or not our client is ready to have these beliefs challenged because we're so used to being with clinicians that do? I'm ready for you to challenge my beliefs. I want it. Bring it on. I'm so sorry we can't sit around the fire pit or in the hot tub and talk about it tonight. But as a patient, I wasn't ready. I didn't know all these rules and Latin names for things that I believed. So consider, are you practicing with the rules that you use with your peers, or have you adjusted for the human in front of you? I do know this. After spending over a decade in patient forums, as a patient and as a clinician wanting to help patients, I do know this for absolute positive sure. Patients come to you because they can't live the life that they want. That is the number one concern, I think, of the person that comes in and says, I need help. I hurt. I can't always articulate that that's why I'm there. And I would say that a lot of our folks in pain can't. And as we've learned over the years, a lot of that has to do with the changes in the brain that happen with persistent pain. But that's why I need you, the clinician, to do all that third space stuff and create a safe space for me to tell you what's really happening in my life because of my pain. I need you to ask those intuitive questions and practice that MI stuff to draw things out of me. I need you to help me live my life. So these soft skills that we learn, these amazing opportunities like the one we're attending right now, these are giving you the skills to help that person figure out how to get back into their life. Because if it hadn't been interrupted, they wouldn't be seeing you. Funny, isn't it? That it might not actually have been the pain that was so bad, but the dysfunction and the interruption of their life. Funny thing about having a life interrupted, it often creates that thing we talk about, that dependence, that sorrow, that learned helplessness, right? We see it in our patients all the time. They believe that there's nothing they can do to get better. And the longer they've been at it and the more people they've seen, the truer that is. So if we know resilience and self-efficacy are important to a patient, a person in pain getting better, I'd like to challenge you that maybe dependence from the client to the clinician is not as dirty of a concept as we often think. Now, if you're providing low quality care and they're dependent on you to rub their hurt bit, that's a different conversation, and we can have that over drinks after this session. But if you are caring for them in a high quality way and you are encouraging them to get back to the things that they love and that they've lost, I'm going to suggest to you that often the patient that has become helpless is going to need a crutch. We give people walking aids all the time in physical therapy because they need help. Yet, behind the scenes on the clinician side, we often talk about, how this is, that a patient may seem dependent on us. Now, of course, we don't want any, we do no hanky-panky, none of that. We don't want that. But the idea that you may be the only person that this person is being honest with, that as a clinician, in your clinical role, doing your very professional job, that they actually may be dependent on you for encouragement that they can do the things, maybe that's not so bad. Aren't we dependent on our friends, on our partners, on our loved ones? I'm a little dependent on my barista. I mean, I can't make a latte the way she can. So I'm a little dependent on her or my local bartender to serve my Manhattan the way that I like. We are dependent on people in different ways. And so maybe the idea that our hopeless and helpless chronic pain person, that maybe, just maybe, it's okay that they depend on us while we show them how amazing and resilient they are. We have the opportunity to take that and turn it into something beautiful. We get to show them what they can do. And we get to be cheerleaders. We don't have to fix anything, but we do get to help. And how amazing is that when in our jobs, no matter what it is we do, we get to see that spark of understanding within our client that they can do this thing. They can tie their shoe. They can get up out of a chair. They can ride their horse. They can do these things. And that pain doesn't have to stop them. I think it's kind of amazing that we get to do this. And maybe as we show this person how resilient they are and that they can solve their problems, that they become less dependent on us without us having to do a darn thing. I was listening to Joe Tada's podcast with Adrian Lau this week, and it impressed me that Adrian was able to say, not everybody needs pain neuroscience education. It's helpful to some, but not to everybody. And Lord knows I'm a learner and I'm an explainer, and I think everybody wants to know everything I know. I love learning, so doesn't everybody that I'm speaking to? The answer is no. The answer is not everybody wants to know. Not everybody wants to know about glia cells. They don't. Not everybody wants to know about hyperactive nervous systems, even if we're talking about it like car alarms. Some people don't need to know. And I'll admit, even as I present this to you today, I am still trying to wrap my head around this. But I know it's true because I watch people's eyes glaze over. And I watch them say, great, I just want to be able to walk around the block with my friend. None of this is relevant. You know what? They're right. We don't always have to explain everything we're doing really for any reason. I mean, there's a lot of reasons we do it, isn't there? But the fact of the matter is, we don't have to. What we do need to do is we need to help people get back to living the lives that they love. And often, we need to learn to ask permission. I'm still learning. I'm sure you are too. I would love to hear stories of how this has gone well for you or poorly for you in the question and answer segment. But I do know that we don't always have to give the science to people. I say this because in needing to put money in my said sciencey things when I shouldn't have jar, I've also learned that in creating that rapport with my clients, one of the most important things I can do is apologize when I see that hardness come over their face, when I've said too much or I've questioned too much or I've thought I was being helpful and I really wasn't, because I was so excited about the thread I was pulling on. In all of these wonderful, wonderful things that we have learned how to do this week, we're going to make mistakes because we're human and we're imperfect. And you know what? It's okay. It really is okay. What I would encourage you to get really good at is learning to apologize to your patients, clients, whatever term you're using. But I would encourage you to become someone who is humble enough to say, I'm so sorry that I didn't ask you if I could tell you about that. I feel like I've hurt you. I see this expression on your face and I'm not sure what it means. I'm concerned that I may have damaged our professional relationship. And if I have, I'm terribly sorry. I get really excited about this stuff. And I love seeing XYZ out of you. And I just thought if I told you that maybe it would help you. But I can see that's not what happened here. Will you forgive me? Can we try again? Having conversations like that with my coaching clients, I honestly can't believe the results. They're astronomical because they say nobody's ever apologized to me before. Well, maybe we should. Maybe that's part of the rapport that we're supposed to be building. Maybe that's part of our honesty and our vulnerability. Maybe that's part of what we do as clinicians to be different, to be better. By reading our patients, looking at their facial expressions and their body language as to how they're responding to the things that we're saying or the accommodations that we're making for their exercises. Maybe it's in these moments that we have a potential to give these people more of their life back than we even understand. I think it's an important thing to consider, and I really do think it's a skill that we need to practice. Do you tell your patients you're sorry when you've hurt them with information? I challenge you to start. The last point that I have for you today is going to be challenging. Ben Cormack and I were having a good discussion, and this came up, and his response was so overwhelming that I felt it really important to include tonight as we look at the different experiences between the clinician and the provider. And the last thing is this. I want you to know there are very, very few chronic pain patients that are willing to tell you the truth about how well things worked in clinic. You see, they've spent a lot of time in and out of doctor's offices. They've used up a lot of credit with their friends. They may have been going to PT or massage therapists or chiropractors for a very long time. They've acknowledged that you're different and you listen. And so they really don't want to do anything that's going to upset that balance. Even when you tell them you want to hear the truth. Because the truth is, we need to believe we're getting better. And so if your intervention helps us even a little bit, the likelihood of us saying, yes, that worked, is very, very high. You see, it's survival. Because there's something that's at least helping a little. And whether it's your cheery personality or the question that my PT asked me every time I walked through the door, how's Amy doing? He was the only one in my world that asked me that. There's care that that clinicians take of the people in their charge, especially good ones, like the clinicians here. And so I encourage you to consider your patient has become very good at surviving. They've learned to adjust to the system. Most of us understand the game that we play, giving pain ratings and how insurance companies work, and that there's pain numbers that we can give that will allow us to continue on in therapy and numbers that will not, on both ends of the spectrum. We can't be too bad because change needs to occur. But we can't be too good either if we're not ready to live our lives. Would you consider for me asking, before discharge, would you please consider asking your client, do they feel ready to go out on their own? Have they met their goals? I can't tell you the number of tearful conversations I've had with people that were discharged from therapy or chiropractic care or massage care that weren't ready to leave and felt abandoned by providers. Providers totally thought their patient was ready. They absolutely did, because why would we kick somebody out? And if it was insurance, we'd be complaining about it, right? But I can't tell you the number of conversations I've had with people that didn't want to tell their provider they weren't ready to be discharged because they were afraid of looking whiny, but then came to me and cried for hours because they weren't living in their life yet, but their pain was finally starting to get better. All these situations are real. They happen with people that I talk to all day, every day. And I know I am always a proponent of encouraging you to lurk in patient forums so that you can see these things for yourself, because it really is eye-opening. So consider being a stealthy fly on the wall in patient forums and taking a look at what happens when they're outside of your earshot. And know that sometimes it is the best of times for you, but it's the worst of times for them. You guys are all amazing clinicians, and I am honored to be among you today. And I'm thankful that you've listened to this chat. And I do hope that you've managed to grab yourself a drink. I know that if we were at the Dana, I would absolutely have a drink in hand because, well, we're at the end of our time together again. We'll have to wait till next year, when hopefully we'll be able to get together in person. We'll share stories, we'll share triumphs, we'll share how we've applied the amazing lessons we've learned this week over the last year, and then we'll learn new ones. It has been an honor to spend this last half hour with you, and I do hope that these talking points have made you consider what it's like to be on the other side of the table, why you get resistance or answers that you do, and that as you're practicing all of those other amazing things that you've learned, that you'll remember at the end of the day, it's a relationship. I know it's professional, but it's person to person, and it's a relationship that you have with your client. So don't forget, it's okay to apologize. Here's to a better 2021, and I'll see you in the question and answer section.